My name's Zoe. I'm one of the consultants over at the Royal. We're going to talk about, try and talk about referrals a bit, so that all of those people that are new to ICU can have an idea as to what we say yes to and what we don't. That's the idea. I did that really. Right. So we're going to try and talk about a bit about a standardised approach to referrals, which I don't think there is one, to be honest, but we'll have a bit of an idea. And then you guys can have a go at decision making. It's all interactive, so the more you join in, the nice thing is that it's all anonymous, so you can join in as much as you like, and we won't know who said what, so you don't need to be scared of it. And the thing is that you can all realise that everybody has a different opinion, and there's no one right answer, to be honest. So if everybody wants to have a look on their phone, and have a look at the QR code, or at any point the instructions will keep being there, so you can join in with put the code into menti.com, and either works. I'll leave it there for a minute. So like I say, it will give you the opportunity to vote as to the answers to what the questions are. It will also give you, at the bottom, you can comment, and you can also ask questions. The comments will pop up on the screen, the questions will pop up when I click on them. And also, when I give you a little case presentation, there'll be a thumb up or a thumb down as an instant first reaction if you want to, just so you can see. Everybody's got that? Happy? Okay. So the idea is that all of this, you follow what the 4 pillars of ethics are, regardless of what we're doing. And we're trying to do good. We're trying not to do harm. Most of what we do on ICU causes harm, so try and do that as little as possible. Justice often involves doing the most good for the most number of people, which can be quite difficult when it comes to beds and rationing and things. And then autonomy is let the patient decide whenever they can, as much as they can, as to what they want to do and when they want to stop doing things. So first question, how important are these things, do you think, when you're deciding to admit a patient to ICU? Is it important what the patient wants? What the referring specialty wants? How many empty beds have we got on the unit? You could do it based on an ideal hospital where we have an unlimited number of beds. That would be nice. Is it important to actually know what's wrong with the patient? I quite like this, it's quite fun. Keeps changing. Most people are saying kind of what I was thinking, to be honest. It's nice to know what's wrong with patients, but I'm knowing exactly what the diagnosis is isn't necessarily important. I think it helps a bit as to what you're gonna do. But if you don't know what the diagnosis is, but you can just treat them by organs, then it doesn't actually matter that much. Probably. Is it worth it? Is the important question, I suspect. Cool. That gives you an idea of what we're doing anyway.
What I find surprising about that, and maybe it's because of how people are interpreting it, but is it worth it? I would say is the most important.
I think it's the most important.
Because if it's not worth it,
don't do it. It hurts.
Anyway.
Yeah, I think is it worth it is the most important.
But the other bit is how many empty beds are there on the unit? So as the consultants on the call, what did you score that as?
Difficult to know.
Did people hear me?
Can you guys hear what Dr. Flynn's saying? But don't know if there are any other consultants on there today.
So I scored that as the lowest possible.
Yeah, I think I would put that at the bottom. If a patient needs ICU, then we'll figure it out.
So I don't think it's important.
Cool. I think the same thing. Okay, so when you're trying to decide, when you get a referral, these are the 3 questions that I asked. I think Dr. Flint taught me this a long time ago when I was a baby doctor. But so we'll talk about each of them. So organ support. Does the patient actually need organ support? And what organs can we support? So there's the ones that I thought of. There might be some others that I didn't think of. Probably the most common thing we get is low GCS and aiding airway support. You might have obstruction from trauma or an infection as well. Respiratory is really common, so type 1 or type 2 respiratory failure can do invasive or non-invasive support. The cardiac is usually, well, here it's for low blood pressure. At the Glenfield we post-op most commonly, but it might be because of out-of-hospital cardiac arrests and arrhythmias and stuff. And we can give vasopressors and inotropes. For brain, it might be because it's impaired because of drugs, because of seizures, because we've had a brain injury, whether that's stroke or trauma or hypoxia or whatever. And there's a lot of what we do is prognostication actually and keeping them for a while. Occasionally we admit people because they need a higher level of monitoring than can be done on the wards, and that's usually a conscious level thing, so checking airways, or sometimes for blood tests for people that have got DKA, that kind of thing. Kidneys, so we can support kidneys, and that's usually most commonly patients that have got multi-organ failure because of sepsis, but it might be because of hypokalemia or fluid overload or really acidotic. And that might be for patients that have got end-stage renal failure and normally on dialysis, who've missed their dialysis for some reason, and metabolic stuff as well. So they're the main organs that we support in general. Next thing you need to ask is it a reversible condition? So are they, sorry, we've been provided with lollies. I probably can't eat a lolly and teach at the same time. I'll have one after. Sorry, reversible condition. So there's probably more than I thought of, but if somebody's bleeding a lot, whether that's intraoperatively, whether that's an obstetric hemorrhage, whether that's pharyngeal bleed or ulcer bleed or PR bleed or whatever it might be, people that are having a major hemorrhage usually need support after the hemorrhage has been stopped. If they've got an infection, then we want to treat the source, ideally. That would be good. And that will be, we can support them through the infection, but if we can't treat the source, then it's going to be difficult to make it better. Trauma of whatever reason, whether that's physical, what you think of when it's trauma, whether that's a brain injury, or whether that's a cardiac arrest. Drugs can have lots of things that cause problems that they need supporting through. But actually, probably the most common thing, other than infection, is actually exacerbation of an underlying condition. And is that a treatable exacerbation or not? Or is it just an expected deterioration of their condition and it's not actually reversible, it's more like terminal decline type thing? And then finally, have they got functional reserve to deal with whatever the problem is? So what activity do they actually do? They usually, when we get referred, we usually get told they're independent with their ADLs. But what do they just sit on their chair and maybe move 3 steps to the toilet and then go back again? Or do they actually go out walking and cycling and stuff? How much quantity of life is what I put there. So what is their prognosis? Often it's thinking about, have they got underlying cancer? What's the prognosis from their cancer? Is it treatable? And then more important than quantity of life is quality of life. So are they independent? What's their cognition like? and how frail are they? Are they going to be able to get back to an acceptable quality of life by getting through whatever we're doing to them? And then think about what options there are. Is there something else that can be done that's more acceptable to the patient and more acceptable to us? Maybe less invasive, maybe out of hospital. I know when my gran was in hospital, her main aim was to get out of here and not come back. And then finally, it's the wishes of the patient and the family need thinking about. And what do they actually want to do? And if you explain what we're going to do, what they often say, actually, I don't want that. So I made a little, I know it's got lots of little images on it and diagrams and stuff. And it looks like quite a lot of things to think about. And it is a lot of things to think about, but mainly it's those three questions as to whether for each referral, whether they actually need support, whether it's reversible, and have they got the functional reserve to get through whatever we're doing to them. So, I'm going to let you decide. I'm going to do some cases. So, probably, I don't actually know if it's true, but it feels like the most common thing is we've got a low GCS downstairs. It feels like we're going to have, that's the most common thing that we get calls for is low GCS. Do you go straight downstairs or do you deal with it and ask for more stuff? It's more half and half than I was expecting it to be, I have to say. I always say generally ask for more information as to who needs to go down and how quickly, especially when you're on your own overnight and there's a limited number of resources. It's useful to know what's going on.
And it's not a referral.
It's not really a referral, no. It is what you get asked, but it's not actually an acceptable referral to be honest. Okay. So you get a bit more information. Call from ED. You've got a 24-year-old woman who's had an overdose and has a GCS of 5. So 2 people say they've taken. That's cool. Okay. So what will you do with her? Will you put a tube in straight away? Will you just bring her up to the unit and watch and see what happens? Or will you just see what her GCS is and see what's going on and decide what you're going to do? That's kind of what I hope people would say, to be honest. You can usually, probably most often, if you go down to A&E and assess the GCS yourself, then you can usually get it a few points better than whatever they put it as, to be honest. People have different ways of assessing GCS. For the pain stimulus, what I quite often do is press the nail bed on each hand with a finger, and that way you can see if there's any lateralizing neurology. And just keep doing it until they move. That usually works.
Please don't do sternal rubs.
No, don't do sternal rubs. It causes lasting damage. Yeah, and actually the trend is more important. So if they might have come in with their GCS of 3, half an hour later it's 6, you do it half an hour later and it's 9. That's probably a good sign. If it's going the other way, then you might want to do, you might have to do something sooner. But the trends are actually more important than the actual number. Okay, cool. Next one then. So you call from ED about a patient with a GCS of 5 still. This one is an 85-year-old who was found at home unconscious and having weed and food everywhere. And nobody knew how long he's been at home unconscious. He's, like I say, he's got GCS of 5, he's got a left dilated pupil, not really moving his one side. And the ambulance, the paramedics tell you that he's frail at home, but not really got much more than that. He looks pretty frail. So people are saying down. Cool.
Is this to address poisoning?
Yes, the address of this one.
Yeah, use the mentor.com and stick the code in. It'll take you to the right place. Yeah. Would you immediately intubate him and take him to CT, or would you escort him to CT without a tube?
It's not an option for ask them to escort to CT.
No, because I haven't done that, but generally they won't do it anyway. Cool. So most people take him without putting a tube in. Okay, next question then. We take him to CT, it shows a massive intraparenchymal bleed with intraventricular extension. Would you admit him to ITU for plastication, would you palliate an ED, or would you admit him to ITU for palliation? And it's changing colour, it's pink and blue because it's whether you answered, you said you'd tube him or not the first time around. If you said you tubed him the first time around, then it's blue.
I see.
And most people would palliate an ED. So if you, I think it's somebody that we probably wouldn't admit to ICU because he's really frail, he's got a pretty terrible prognosis. It would be nice to be able to admit everybody to ICU for palliation because it's just a nicer environment than somebody dying in ED. Unfortunately, we just don't have enough of that. So I suspect this guy would not get tubed. When you're deciding whether you would tube or not to go for CT, you need to know, to be honest, neither's right or wrong. You need to decide, you need to know that you're comfortable with doing something at the end. So if you're going to palliate, are you comfortable just taking the tube out and seeing whether he breathes himself? Or are you uncomfortable doing that, in which case you probably wouldn't want to tube him? It doesn't really matter, but it's just, I suspect both answers are right. If you were in Queens, then everybody gets a tube and then they get their tube taken out in ED. Here, we tend to not tube them and just escort them for CT without a tube. So just a cultural thing, to be honest. At Queens, there was a lot of intubating and extubating on in ED. The patients that wouldn't come to ITU.
I guess that's kind of one of the ones where is there any situation in which you would be supervised?
This guy?
Yeah, like given the history.
Depends how frail he is, I suppose. And what he would want, or what his family would want, maybe. But I suspect probably not.
I think that's where the advantage of not intubating comes in. Because obviously intubating is pretty.
Presumably you would use something
It gives more time to answer the plan before you actually committing something that actually potentially is more crucial.
Yeah. Okay, next one. Younger guy, had a sudden headache and then collapsed, so it's fairly predictable what actually happened, but still has a G65, no known significant past medical history. So would you intubate him and take him to CT? Same question really, or would you just go him to CT without a tube in the same way as the last one? Just 40 odd years younger. Yeah, I thought that people might say that. So I think I would do the same. Because this guy, you probably would take to ITU, unlike the other guy. So it just gives you a bit more control. Okay. They've taken the CT, shows a big subarachnoid hemorrhage, predictably, with lots of badness and herniation and things. So you ring the neurosurgeons and they say, no. So would you admit him to ICU? Would you aim for prognostication, palliation, organ donation, or would you just palliate in ED?
So neurosurgeons do nothing. They've got new tiling.
If he wakes up, they say if he wakes up, they call us back, which is what they normally say. I think, to be honest, it would be really difficult to palliate this by an ED. And actually, I can't remember when the guidance came out, but the latest one says that if somebody's got a severe brain injury, then actually we should prognosticate after 72 hours, because some people do actually do a bit better than expected. Even if you've got a horrendous CT scan, you can wake up, theoretically. So we should admit, if we would otherwise admit them to ICU for anything else, then we should carry on admitting them to ICU and prognosticate after 72 hours. So what we normally do is put them on short-acting sedation and just see what happens. Do neuroprotection, do as much as possible to reduce their intracranial pressure, and just see what happens. And then often, to be honest, it is palliation, but after 72 hours. And we will say the organ donation question will be broached at some point, but only after we've decided that they're dying, or they are brain dead potentially. So don't bring it up in the first conversation whenever you talk to families. It's a later thing once they've accepted the patient's dying. Otherwise, it sounds like you just admit them to nick their organs and you don't want them to survive, which families don't really like. So don't do that. Okay. New patient. 68-year-old lady with septic shock, secondary to pyelonephritis. She's got some hydronephrosis on a scan. Got a bit of a diabetic background, but not too bad. She's had 3 litres of crystalloid downstairs. And the blood gas. People are generally happy. If you didn't know what the blood gas was, would it make a difference to your decision? If it's 3 in the morning and somebody rings you up and tells you what the blood gas is, but number by number, are you actually going to listen and understand what it says? No. Don't read me a blood gas at 3 in the morning. I won't take it in. It's not actually helpful. And to be honest, it's the hypotensive and still acidotic is all you need to say, despite having fluid. It doesn't matter what the number is. If it's 6.9 or if it's 7.2, it doesn't matter. You're still going to admit them probably. Okay. Got traffic lights. Would you bring this lady to ITU? Would you give her some limited support, or would you not admit her? I think she's not for ITU. Cool. I think that's what everybody else would do, to be honest. Admit her to ICU. So what are you going to do for her? Put some lines in, give her some more fluid maybe? Anything else? Antibiotics, yeah. What do you think is the most important? You probably do many of these things. What do you think is the most important part of her treatment? Fluids, renal replacement therapy, vasopressors, nephrostomy, or antibiotics? I like this one because it changes as people put answers in, so you can see which one the top priority is. What's actually going to fix it out of these things?
Because it's most important on first. I think the first thing you've got to do is make the process and you've got to get it. Antibiotics.
I think it's special. You can't do everything when you're like, can do it.
Yes. Which one's going to cure it? Yeah, the nephrostomy is going to be the thing that makes it better. If you leave the pus in there, even if you give her antibiotics and vasopressin and stuff, if the pus can't get out, then she isn't going to get better. So even if it's 3 in the morning, the interventional radiologist needs to come in and put a nephrostomy in her, and then by the morning, she will probably be mostly off of vasopressors. That's what normally happens, and they're getting better.
Do they come in with that?
Yes. If you ask them, they will do. You just need to be forceful about it sometimes. But yeah, they will come in, and it does work, and it is worth it. It makes them better. Cool. Okay. So this is probably somebody that comes into Glenfield regularly. Got a 56-year-old man who had an out-of-hospital cardiac arrest. His first rhythm was VA, and after 25 minutes he had a ROS. Now, he's got a GCS of 4 and he's tolerating his eye gel. The paramedics put in. The cardiology wants to take him to cath lab. This is one of your STEMI notes that comes off to your bleep. Most people want to take him. Cool. Do you agree with these things? Will you take him to cath lab? Will you then admit him to ICU? Will you change the eye gel for an ET tube? Will you give him some sedation, or will you not bother because he's got a GCS of 4 and he's tolerating it? Use eye gel. Will you wait to get up downstairs to get an outline in? Or you do nothing, just leave? I'm kind of glad everybody wants to do nothing. That's good. Yeah, I think take him to cath lab and then to the unit, assuming that he survives. I would change the eye gel for an ET tube at some point when there's time. If he's tolerating it and he's oxygenating okay, it's not a priority, but it does need doing at some point. And to be honest, I think sedation is quite important. I haven't done it at Glenfield for quite a long time, but I think that from a neuroprotection point of view, even if he's unconscious, he still needs some brain protection. And yeah, I wouldn't delay anything to put an outline in. It's the same if you're doing a neurotransfer to Queen's. If the ambulance is there, don't make them wait to get an outline in, just go. It's a priority is revascularising him or getting blood out of his head, whichever. Not sticking lines in. Cool. What about this person who's had an arrest then? 82-year-old out of hospital cardiac arrest. When he was found, he was in. Got ROS after 15 minutes. Got a GCS of 3. And a distended abdomen. Not really a great background. Might have a ruptured AAA, but it wasn't felt to be electively done, so nobody really knows. So I think he's got a AAA, ruptured AAA. What would you do with him? Take him to theatre and fix it, palliate in ITU, palliate in AD, or do something else. If you want to do something else, please tell me what you want to do, because I couldn't think of anything else. Why it says other. Good. Everybody says palliate and ED. Very consistent so far. They do get a bit more difficult though.
You want to know what the comment is?
I know, I want to know what the comment is. I won't move it on for a second. The first ones were fairly straightforward, hopefully. And then, yeah, it made them a bit more complicated. Okay, confirmed diagnosis with CT or fast. Yeah, that's fair. We can get them to do a fast scan and just make them see. And if they can't see, then you could do a CT scan. Walk around and just see if his heart keeps going on. That seems reasonable. Okay. So you've got a 50-year-old man with alcoholic liver disease. You get a call from the medical admissions unit. Still drinking. He's a bit overweight and diabetic. And he's having a varicose bleed. He's hypotensive, having some ONA transfused now, and he needs an OGD under general anaesthetic in theatre. So, would you admit into ICU or not? If you're putting limited support, how much support would you give him? What would you not do? I'm going to level 3. Give him 72 hours. Yeah, that's kind of what I thought, to be honest. Give him full support for 48, 72 hours and see what happens.
It's a presentation, isn't it?
Yeah.
It's first ever GIP.
Yeah, if it's his first GIP, then you kind of treat it probably.
It's probably going to take him to see what happens. If he's had long-term engagement with the hospital and isn't engaging with the process of stopping treatment and is coming in and out, it's a very different story.
Yeah.
I did have this situation happen when I was in community. We had somebody who'd been only the week before had fled, and I think he had been treated okay. And then at some point we were saying to them, if he rebleeds, we can't keep paying because we're not solving the problem by banding.
Yeah.
And then the gastro person was horrified and said, "You just want to let him bleed to death. It's a treatable condition." And that was difficult to answer.
Yeah, it is a very reversible condition at the time, if they can stop the bleeding. If they can't stop the bleeding, then it's much less reversible. Saying statin sometimes works. Not always. We had one a couple of weeks ago that it didn't. So yeah, I think probably most of us would probably admit him and give him full treatment for a couple of days and see how it goes. Or give him limited support at least. Maybe not give him renal replacement therapy. Give him some blood and see. Okay. So the same guy, he came in with a varicose bleed, now he's septic on the ward. He's hypotensive, he's got a raised lactate, he's drowsy, so he's encephalopathic basically. And they're giving him fluids and it's not making any difference.
Is it varicose bleed now fixed, or
His varicose bleed stopped and now he's got an infection. Probably a hospital-acquired pneumonia or something, that's what. Okay. So would you have him back, basically, is the question?
Some of it depends what we found out in the previous one.
Yeah, that's very true. You are, once you admitted them the first time, you are more likely to find stuff out about him and get a bit more of a story. did base these on real cases, so I know sort of they're adjusted, but took them out of the referral boxes that we've got in there. So I do actually know whether we admitted them or not. No. I think we probably would do progressive lead, but it didn't, because I think it depends what he's like and how many times he's been in and stuff. If it's an ongoing alcoholic liver disease, cirrhotic, been in many times with a massive abdomen because of ascites, that kind of thing, we would probably say no, to be honest. Agreed?
Yeah, I agree, yeah. It's all context specific, isn't it?
It is.
You may well end up with missing for limited support, but it will become more limited than it was the previous time.
Yeah, definitely. I don't think he's somebody that you'd want to give real replacement therapy to. At least you agree, that's fine. Cool. Okay. This is a fairly common, or relatively common question, I think. You've got an older lady with a background of CCF and CKD who's very dependent and can't really walk anywhere. Who's got an infective exacerbation of COPD, which she keeps having. At the moment, she's only on 35% oxygen through a venturi, presumably. But the consultant from the medical ward has asked for an opinion as to what to do if she gets worse. Would we take her or not? And they do ask that kind of thing relatively often, I think. And it is kind of to be encouraged because it's better to do it in daytime. And you can talk to people and talk to family and get time rather than when they've arrested at 3 in the morning. So would you take them or not? And would you tube them or would you do NIV only? Would you do NIV on the ward or on the unit? Well, that's fairly emphatic. Fair enough. I think we like to think that we can do NIV on ICU better than they can on the ward. I think a lot of that is nursing ratio. You've always got a nurse looking at the patient, so you make sure that the mask is fitting and that they're tolerating it and stuff, rather than abandoning them in side room for 4 hours. Don't know whether that's true. And you could do NIV on ICU if you've got beds for it, but generally we usually don't, to be honest. Probably say senior care ward for maybe.
These ones, if you look at our excellent stuff about evidence for COPDs and how they do not see a while back, and actually their functional state doesn't seem to dictate it that much. It's all about whether they actually enjoy their life. At the biggest effect. Well, this already got CCF, CKD in there, but the biggest question for me when it's in these guys is, what's your life like day to day?
Yeah, I think
quite a few of them will tell you it's the day they struggle to breathe and they don't want to.
Yeah, I think if people enjoy their life and it doesn't matter what's wrong with them, they're generally more likely to try and get out of here, aren't they?
The absence of CCF, CKD on my end would be the ICU.
Yeah.
Can you see on them ICU and then you have like invasive monitoring to go along with it? Because the new.
You can do, yeah. If we could put an outline in and then do gases and stuff.
Because the lid is the same, it's just, yeah, if you want to heat, you then sort of force to each better.
That's the problem.
Do you force to do anything?
Not force, but it's like why just stick it to NIV, why should you run the escalator further?
It's just a higher quality nursing care. You think that you
Yeah.
do it, but she probably would recover to the best possible version of that care, then that might be reasonable space. Whereas if you think that regardless of them on, she often can do any better with those over there, then it's not good.
But that's not so-
Hard decision to make.
it's not a medical- Visual operation is more just logistical other issues by itself.
Yeah, I'd argue there's some medical effect as well. You look at sort of who's looking after them on the ward.
Yeah.
You know, if they're on a respiratory ward having an IV, you think it would be better, but it's on a general medical ward.
Yeah.
You know, how, you know, it's not saying that individuals aren't good at dealing with it, but it's the, you know, you've got to go work to the lowest common denominator in that firm, but they all know how to use the IV. And they're comfortable taking it, doing that sort of stuff.
Yeah, patients not very but I would fill it.
I remember reading a study about COPD, the patients with exacerbations who get integrated and they eventually get extubated within the first week. 80% of those patients are actually not to be considered for intubation and to come back the second time with exacerbation. Whereas if intubation is prolonged beyond 2 weeks, very few people will choose to get intubated instead.
It's more likely to get tracking if you end up doing that. People don't want that. But it does make a difference as to where they are. As Neil said, I think if they're on ACD here, so they are inside room on their own on an IV, it's not the same as having an IV on a respiratory ward at Glenfield, where the nurses are used to doing it and the doctors are used to doing it. We found that during COVID because we ended up admitting anybody that was on CPAP that we would escalate on ended up having their CPAP here, whereas at Glenfield they had their separate wards for the ones that they would escalate on, and they would wander around and check on them most days and just see whether, or every day at certain points, do a walk around there to see whether they're doing okay or not.
Well, it's more like respiratory HDU, but if I as well manage that really well.
Yeah, there are places that can do it, just not at the Royal, unfortunately. Okay. Different patient. So, new Guillain-Barré syndrome, actually fairly well previously. It's got a forced vital capacity of 1.1. In neurology, we're getting concerned about him. Most people seem to want to take. So, should all patients with an FVC of less than 1 be admitted to ITU automatically? You admit him when he has dysphagia. You give him admit him when he needs oxygen. And when you talk about trachea. Quite what I expected, to be honest.
No, it depends how you read it, doesn't it? You read it, oh, admit him when he has dysphagia, if you're waiting till he has it, then you could admit him. Whereas if someone had dysphagia, I would admit them. So I just call it quite over. Potentially, if I saw someone who had dysphagia disaster, I would admit them. But I wouldn't be waiting for that to admit them. So I want
Maybe I need to change the wording on my thing.
how other people put it. And same with oxygen, you know, if they were on, I would admit them, but I wouldn't wait until they were on.
The FVC of less than 1 is what usually triggers a phone call. Usually, it's actually the number doesn't matter that much, and actually, if you get them to do it again with a decent technique, you can usually improve it and just see or make it more accurate at least. And I probably would be more concerned about the dysphagia and this after and needing oxygen as to how quickly I would admit them. And yeah, they're gonna need a tracheostomy. It's gonna be a long time generally if they end up intubated for Guillain-Barré syndrome.
The medicine, what's the mortality of Guillain-Barré patient? We used to get over.
I don't actually know. Anyone at Glenfield know what the mortality of Guillain-Barré is?
It used to be quoted as 10%. But if you get admitted to ICU and ventilated, it's 37%. So 37% in those things.
So 1/3 die, 1/3 have significant neurology, and 1/3 are okay.
That's the only thing that's changed.
not sure the treatment's changed significantly. If you don't need ventilating, then Diabara has actually got a reasonable prognosis. But if you do need ventilating, it's bad. And they'll be with us for a long time, so you get to know them very well. And they end up with lots of photos in their room, generally. That's what happens. Okay, get a call from hematology. An old guy, older guy, who's on, got stats of 93% on 15 litres. It's pretty well. He's got mantle cell lymphoma. Can you help? So you go along and see him. When you actually see him, the numbers are right. He's got moderate work of bleeding. He is independent, but he's felt slowed up, so he's not really doing very much. And he's got mantle cell lymphoma, but it's actually chemo-resistant, and he's got rapidly progressing mediastinal disease, which is causing his respiratory failure. Okay. Did you take him or not? It's all about how reversible this is. Yeah, I think, well, again, this is based on a real case. And it was felt that his mantle cell lymphoma didn't have a treatment option. So he wasn't admitted. I do remember admitting a similar patient who was admitted when I was an SHO, and it was a new diagnosis of a relatively young patient who had mediastinal lymph nodes, and I remember having to take him on CPAP to radiotherapy to have his radiotherapy, but you couldn't have oxygen in the radiotherapy room, and they needed a lot of oxygen, so you'd have to turn it off, run out of the radiotherapy room, do the radiotherapy, run back in, and to put it back on before he desaturated too much. It was an eventful transfer. Many oxygen cylinders from what I remember. Okay. So you've got a patient who's an older lady with pneumonia. It's also affecting her kidneys and her heart. She's needing quite a lot of oxygen via CPAP mask to get acceptable stats. She's not got a great baseline. So you called from the medical ward as to whether you take her or not. I think this one is about her functional reserve and how can she actually, because she's in multi-organ failure or getting towards multi-organ failure, it's affected all of her organs anyway, and she's going to need a lot of support. And is she actually going to get back to an acceptable baseline if she survived? So most people say no, which I think is reasonable. Actually, the medical consultant that rang said didn't think that she should come to ICU either. But she wanted full escalation, which is why he rang. Would it change your mind? That's emphatic. I think the thing to remember is that patients can't demand treatment. You can ask for it, but you don't have to give something that you don't think is going to work. You can say, if you would like to. And ask a friend, which is why they consult on rank in the first place.
Movement offers a like a menu, you can take it off at any time, they can only pick from that time.
Yeah.
Unless they go to court.
They still, even if they go to court, they can't demand that you do.
They can't.
after started, so that would be about withdrawal.
Yeah, with the court decision.
Well, yeah, I think ethically there's not much difference between withdrawing or something. But legally there is.
Yeah.
Well, legally there isn't, unless they go for permission, there isn't. Because they can make you wait.
I mean, have you had this conversations with the patients like, I want you to say that you're like, no, well, obviously that way, but how do you?
Don't usually say no, you normally have to phrase it a bit better. You have to make sure that they understand what they're actually asking for, and that it wouldn't actually change their outcome.
So we're going to take you to ICU. We're going to give you some drugs. Do a few little bits for you, little lines, stuff like that, and it's all going to be alright, and you're going afterwards. Sounds really quite pleasant, doesn't it?
Yeah.
We're going to take you to ICU because that's you. We're going to have to, give you lots of drugs. It's going to be painful. You're going to end up with tracheostomy. You're going to end up delirious, incapacitated, bed bound. I think you're feeling yourself.
Never get off the
And
ventilator.
probably die whilst on that, having gone through lots of painful procedures that aren't going to make it any better, and you're not going to be able to feel family during this whole process. And therefore, say goodbye or get any of your things or anything you want to. Sound nicer? It's essentially what you've got to try and put it through to them what actually they're asking for, and explain to them actually what they're asking for is not something that we think is in their best interest. And ultimately, you turn around and go, I'm not willing to do this. It's not worth it.
Usually
It's not. It's normally families who have difficulty in explaining to not the patient themselves, the patient actually normally. You turn around and go, it is I wouldn't do this. It's not worth it. I've not had a patient kind of funny with it.
No, I haven't. Patients are alright on there. They're usually quite accepting of the badness, whereas families are sometimes less accepting because they want their mum to carry on and whatever.
You can insist they have a great quality of life. If you've got stuff on that they get to see their family not happy, you still know their bodies and
I had this in the first few months of the consultant. Get called down to the medical wards. A 22-year-old who's got cerebral palsy, she had learning difficulties, non-verbal. She had a hoist to get out of bed into her wheelchair, but didn't actually control the wheelchair. She was pushed around in it, and communicates with facial expressions. Her mum knew what she meant apparently, but it didn't mean anything to me. She had a chest infection, was on oxygen. Her other organs were okay, and the mum was present. And the medics asked to come and decide whether she should come to ICU or not. Mixed response initially. So, would you admit her to ICU? Or not, for limited support or everything? Or would you do whatever the mum wants you to do? That's even. This is what I meant about everybody having a different opinion and there not actually being one single right answer. It's nice that nobody says do whatever the mum wants you to do. You do have to get her on side, definitely. And her opinion does actually matter quite a lot, I think. So it's useful to have an idea as to what you want to do before you actually talk to the mum. So you can encourage one way or the other. But a lot of it might be open to what she says, I think. And actually, when I talked to the mum, she was very sensible, and I talked about what she would need invasive ventilation if she got worse, and what that would mean to somebody who has learning difficulties and can't really do anything. And probably it might well mean that she couldn't get off a ventilator and she had a long-term trachea. And is that something that you would want, or would you want her to die in peace at home or whatever, because presumably she had quite a limited lifespan. And Mum was like, no, we wouldn't want that. I don't want her to go through invasive ventilation anymore. She's done it regularly as a child going through PICU. I don't want it to happen anymore. I don't want her to have a trachea. So we decided to leave her as ward-based care. She could have oxygen if she got better, great. If she didn't get better, then not for invasive support.
This is something that would, these patients who eventually die.
Probably. And it is probably going to become a more common referral as more and more of the kids sort of, the more and more of these kids are getting to adulthood, so they're not going, they go through PLCU every year and they get a chest infection and they automatically get admitted and then eventually discharged. And when they get to 18, then they're going to become our problem. So it is going to become a common thing. And actually, while I was there talking to the mum, the learning disability specialist nurse came in and was actually really helpful and joined in the conversation. And was advocating for her, but agreeing that actually ICU wasn't appropriate in her case. And was able to support the mum with what they would do next, which was nice. So I would say, if you can, get the specialist nurse to come along, so we really help them.
I had things where I've admitted and not admitted.
Yeah.
The difficult ones are where someone, somewhere along the line, within the acute admission, has kind of commented on the learning disability. And then obviously the family get very defensive, aggressive, depending how they are.
They can be.
That's where you have to, it's all about sort of physical capability.
And I think they have a different, PICU is a very different experience to adult ICU. Whether they get admitted or not, and how much time they can spend with them and things like that. So. At some point, maybe we'll have a way of joining up the long-term care of these patients, but I don't know how that will happen.
Pediatric care, people with very bad conditions, is often like a plan for deterioration and how far and what we do, at what point we expect that.
Yeah. Yeah. Pediatrics do that. What we haven't got is a transitional to adult care type thing very well yet. Maybe that will happen as we get playing. Do you have another one? No, that was it. What was it? Okay. So, summary from all that is work out the answer to your 3 questions, and you can use the patient and the family and the clinicians to help you try and find the answer. The trends are more important than absolute numbers. Don't give me numbers over the phone at 3 in the morning. I'm not going to pay attention to them, to be honest. Don't expect to always know the right thing to do or to know the answer. And ask other people, whether it's the registrars, the consultants. The consultants ask each other what they do all the time, and have a discussion about whether to admit somebody or not. There is no definite right answer, and as you've seen doing that, everybody's got different opinions. So, hopefully.
I think if there's a time where you're kind of sitting on the wall going, "Well, should we have a meet this person?" If you never have that, then there's got to be someone who didn't admit.
Yeah.
Then it's always slightly better to err on the actually in hindsight I'll out than the opposite.
It is always easier to admit somebody than to not admit them.
There are times I've admitted people who have done nothing to them. The only reason I've admitted them is because then they've been admitted to ICU. And actually that's made either the aggro from the treating team, who if you like, you've got to take to ICU and again quite vociferous about it. And of course that's a really difficult thing to work out. Or the family, like you've got to take to ICU, this, that, and the other, and it's getting, you can see it getting nasty, it's going to end up oppositional. And you admit them that you don't do anything different to what they do. And so they're very, very limited. Actually, it stops you getting into what can be a really quite nasty situation.
Dr. O'Neill's rule is if you get phoned by the same patient twice overnight, then you admit them anyway. Hopefully that was helpful and a bit more interactive than some of the other ones.
Yes, I think I used to dislike the most about the board training and stuff is in our DGH where you would not go down to the course was that kind of uncertainty.
Yeah.
Something they're going to get a little bit of moment to see something like, you know, I'm not in a nice controlled environment. So, that was the hardest thing.
Yeah, I think going down for low GCS is probably one of the most common phone calls, to be honest, and it's not an easy thing to do. I know when I was at SHO, my reg would send me down and then come down somewhere between 10 and 20 minutes later, depending on what was wrong with the patient, as to how quickly they wanted to come and support me. There's a QR code for anybody who wants feedback and a certificate. Hopefully that was helpful.